Hi, Dr. Schade.
Hi, Darryl. How are you?
I'm good. I hope you are too. Good. Welcome to our conference. Total appreciation for your being here. We're all grateful and looking forward to this conversation. Can you tell us what kind of doctor you are and where you practice?
Yeah, I'm a urologic oncologist at the University of Washington.
And what is that? I mean, do you see patients every day or do you do research or a mix?
Yeah, sure. Yeah. So I'm what we call a 50-50 guy. So about half my time is spent taking care of patients, either in clinic or the operating room. And then about half my time is spent doing research.
Great. So about how many patients a week do you see in your office?
Generally in clinic, somewhere around 25 to 30.
Yeah. So a really good practice. And like about how many times do you do surgery per week?
I operate 1 to 2 days a week.
Yeah. So, and within each of those days, 1 to 3 patients a day?
Yeah, that's a good estimate.
Yeah. Good. So today's conversation is about surgery. You know, the sort of before all these wonderful innovations and things, before robots, before anything, you know, in the Wild West, people would take a sharp knife and try and cut out a prostate or something. Actually, that might be an interesting. I mean, can you like 90 seconds or less? Like, what's the grotesque, morbid history of prostate cancer surgery?
Yeah, I would be lying if I tried to make up all the details, but I'd say that over the last 30 to 40 years or so, there's been a number of advances. First, just really describing the intricacies of the pelvic anatomy, particularly the nerves that innervate the prostate and then carry on to the penis. And just those understanding of that anatomy has really transformed our ability to observe nerves, to try to preserve function. And that kind of led to transition from what classically was the perineal prostatectomy, incising behind the scrotum to get to the prostate, to really favoring what's called the retropubic approach, which is going through a lower midline incision from the belly button down to the pubic bone and approaching it from the front. And then in the early 2000s, that led to the development of robotic surgery. And really over the last 15 to 20 years, that's really taken off. And currently greater than 90% of prostatectomies in the US are performed with a surgical robot.
Yeah, and our opening speaker is Patrick Walsh, who is basically...
That's the man who I was talking about.
Yeah, and I would imagine that this is the world you entered, his world, the world of a clean view of things, understanding where things are. And why is that important? I mean, it's an obvious sort of thing. You want to know what you're cutting, but why is it so critical for prostate cancer surgery?
Yeah, that's a great question. I think that precision is really the key for a number of reasons. The first is there's just a lot going on by the prostate, compared to say a kidney for urology surgeries. There's not a whole lot happening around the kidney. It's surrounded in fat and that's about it. Whereas in the prostate, it's right up against the rectum. It's attached to the bladder. The urethra runs right through it. There's muscles attached to it. There's nerves that are attached to it. And so there's just a lot going on. And so there's a lot for us to be mindful when we're doing the operation, to try to give patients the best possible outcome as far as quality of life stuff, which we can talk about more later. And then from a cancer perspective, unlike many other organs, again, the kidney, the liver, the prostate doesn't have a discrete capsule to it. And so when we're doing the surgery, we don't have that luxury of having a clearly defined margin that a lot of other organs have. And so because of that, we just have to try to be as precise as we can. And the better we can see things, the more precise we can be with our instruments.
So that actually gives a good picture of why it's a difficult surgery in the context of things. I mean, it's just connected to a lot of stuff.
It is.
And yeah, and a lot of tubes for cancer cells to escape from. Let's talk a bit about the prostate. I mean, and there are terms that, so everybody's on a level playing field. You already mentioned the word margin. What does that mean?
Yeah, so the margin refers to the very edge of the specimen. And so when we're doing oncology surgery, our goal is to have what's called a negative margin or a clear margin, which means there's no cancer right at the edge of the specimen. So the idea is to get a little bit of normal tissue between the very edge and the cancer to give us the best possible chance of getting everything out and not leaving any cancer cells behind.
Right. And the prostate does what for us?
Yeah, that's a great question. So its main function is it contributes to reproductive function. And so it contributes about half of our semen volume and secretes a chemical called citrate, which buffers the acidic environment of the vagina to protect the sperm during their voyage.
So and the citrate, is that part of what we call pre-cum?
No, that would be something
No,
different.
the
Yeah,
Cowpepper's gland does
exactly.
something. Yeah.
Yeah.
So, and the Cowpepper's gland is not part of the prostate, right?
Correct.
Okay, so we won't talk about that. That's something else. Look it up. It starts with the word cow, and it's a cool thing. So half of the semen, it doesn't actually come from the prostate. I mean, it's got the prostate shooting out a juice into the seminal vesicles, which is where our other stuff is, where the sperm is and things like that. Is that right?
Yeah, more or less. I actually have some diagrams to try to explain some of this stuff a little bit easier. Hopefully everyone can see this. So this is the male anatomy. Hopefully it's obvious. And this is our prostate sitting right here. And so as I talked about before, it's attached to the bladder. The rectum sits right in front of it here. And then the urethra runs right through it here. And then the seminal vesicles you were talking about are like little bunny ears, essentially sitting on the very back of the prostate. And they're part of the male reproductive tract as well. And so when men ejaculate, prostatic secretions leak into what's called the ejaculatory duct, which is this tube right here, and mix with secretions from the seminal vesicles, which are all kind of plumbed together. And then the semen enters the urethra right here, and the contractions of the pelvic floor muscles then push the semen out when we ejaculate. And so in combination, the seminal vesicles and the prostate contribute for roughly 99% of the semen volume. And the portion containing the sperm from the testicles are connected to the prostate with the tubes called the vas deferens. And so when we have a vasectomy, that tube is divided firmly down here in the scrotum. But those tubes run up through our groin into the belly and then plug into the prostate between the two bunny ears on the back. So everything comes together right here.
And it's a shame that most diagrams show a flaccid penis. I mean, we should have more activity in our diagrams and graphics. The idea that we're cutting something out, usually you think of like why would you cut something that my body made? I mean, I need that thing. It seems like there's like a presumption or prejudice against reproducing when you think it's okay to cut out the prostate. Why is it okay to cut out the prostate?
Yeah, that's a good question. I think one of the factors that contributes to maybe our undervaluing reproductive health is the general age range of men being diagnosed with prostate cancer. Since the peak in age is generally in roughly the mid-60s or so, at least from a purely reproductive standpoint, most of our patients are beyond the reproductive years, but obviously not everybody. But because of that age, there may be a bit of unintended bias or unintended neglect of addressing some of the reproductive issues. Obviously, some men are younger. We see men in their late 30s and 40s and in some cases, and even older men sometimes are interested in maintaining their reproductive capabilities. And so I would say as a clinician, if that applies to you as a patient, then always make sure that your values and your preferences are made apparent to your cancer treating team to address those issues and make sure that we can be holistic when we're addressing your priorities.
Yeah, and from a patient advocacy point of view, all doctors should ask anyone, do they want to have a kid? Now or in the future, whether they're 70 or 80, maybe not a good idea as you get really old, but still it's on the table for people. And the question shows respect at the very least. Sure. The idea that let's back, does the prostate do anything else, anything of any value for our bodies?
Yeah, I mean, for the most part, if you think about evolution, its role is what we talked about before. But aside from that, for some men, it's a source of pleasure with intercourse and anal stimulation. So that's another potential benefit. And obviously that's another factor as far as sexual health and reproductive health.
Yeah. And the urethra goes through it because we need to ejaculate through the urethra. So it's sort of around that. And the prostate is completely around the urethra, right?
Exactly, yep.
But there are ways for things to get, for semen to get in the urethra. Is there an actual like pipe connection, like a Y connector between the interior of the prostate and the tube or the urethra?
Yeah, so this picture doesn't really do it justice, but there is a little opening in the urethra that's called we call it the viru for short. Essentially, it's where the ejaculatory ducts plug into the urethra. And so if we're doing like a bladder scope, or what's better known as a cystoscopy, where we drive a camera up the urethra, kind of just as we get into the prostate, we can see this little ridge with an opening. And that's where the plumbing all comes together in a Y, like you were saying.
Okay. So when you're cutting out the prostate, you're cutting out the whole structure of the prostate and the bunny-eared seminal vesicles.
Exactly.
And then you're reconnecting the pipes that sort of help urine evacuate, from the bladder or out through the penis.
Yep.
But there are also nerve bundles that pretty much every prostate cancer patient knows and is deeply concerned about. Maybe with your graphic again, like what's the deal with nerve bundles?
Yeah, so this particular diagram is kind of a cut through the middle, and I have one here in just a second that goes from the sides. Yeah, here we go. So this is another view kind of looking at us like sliced like this. And so if you imagine, say this is right and this is left, the nerve bundles run along either side, along the back side of the prostate. And so if we real quick then go back to that other view we just had a second ago, I can kind of show you that a little bit better here. Sorry, I have to flip. So they run along this area here, along the back side and other side. And those nerves essentially are coming down from our spine, kind of in front of the rectum and then behind the prostate, and ultimately make it into the penis to control our ability to have erections. And I wanted to point out these are different nerves compared to those that control sensation. And so these aren't nerves that would impact the ability to feel touch or to feel the sensation of orgasm. It's just purely the erection itself. And so when we're doing surgery, if these nerves get damaged, or we have to take them out from a cancer standpoint, we can talk a little bit more about those reasons in a bit, then that can mean long-term decline in sexual function. And so during the surgery, we try to do what's called a nerve-sparing prostatectomy, where we very carefully peel those nerves off the sides of the prostate in order to keep them intact, so those signals can get down from our brain into the penis to cause an erection and maintain it.
Yeah, and we'll talk about that even more detailed and more, I guess, in 10 minutes or 12 minutes or so. But there are men who experience pleasure from prostate massage and from anal receptive sex, where the prostate is, bumped into. But the nerve bundles are around pleasure, around orgasm, that go up to the glands and such. Those aren't adjacent. Those aren't resting on the prostate. So because I mean, reproductive usefulness, reproduction is a big part of prostate. But for many men, prostate massage also means that the prostate is a source of pleasure.
Right.
So. What causes that pleasure?
I think it's a combination from the stimulation. I think it just leads to more rigorous contractions of the prostate when you have an orgasm, as far as the climax itself. And aside from that, I think it's just that potentially that sense of fullness and manipulation of the prostate. And there are sensory nerves that go to the prostate, and they're going to come out of a different location and ultimately make their way to the prostate. And so that is a factor. If we're doing a prostatectomy, if those sources of pleasure are important to you as a patient, then that may impact your sexual quality of life afterwards.
Yeah. So is there any reason other than cancer to actually go into the body and remove the prostate and the seminal vesicles that are attached to it?
Yeah, so Really, the only reason we would take out the whole prostate is for cancer. Maybe there's a few very rare exceptions, like very bad fistula or something like that, where you have a connection, from two organs that aren't supposed to be there. But aside from that, really the only reason we would take out the whole prostate would be for cancer. We do lots of procedures to more or less ream out the prostate, sort of like a roto-rooter or something like that, for men who have an enlarged prostate, where the prostate's starting to get bigger in this middle portion here and pinching off the urethra from either side. And so in those settings, we will either scrape out the inside of the prostate, or sometimes do what's called a simple prostatectomy, where we actually shell out the mid portion of the prostate to create a wide open channel for us to pee through. But those are done for benign indications as opposed to for cancer.
Actually, I've never heard the phrase shell it out. I mean, you're actually, but you're going beyond the urethra and going into the prostate and scooping stuff out?
Yeah, so if we do what's called a simple prostatectomy, we're removing the center portion of the prostate, what's called the transition zone. And that's the part of the prostate that gets enlarged as we get older with what's called BPH, or benign prostatic hyperplasia. And naturally, the way those tissues are attached, there's like a very thin membrane. And we often describe it to our patients as peeling an orange from the inside out, where we leave the peripheral part of the prostate, which is where most cancers occur. That would be the rind of the orange. And essentially, we're just peeling the shell, or excuse me, the fruit of the orange from the inside out. And there's a few different ways of going about that. But when we do that, we often go through the bladder. So the part that we see is naturally the kind of the fruit of the orange at the junction of the bladder. And so that just gives us access to peel that inside out and leave the rind of the orange in place. Unfortunately, though, like I said, with prostate cancers, most often those occur in the actual peel of the orange. And so we're not able to do that procedure for cancer in most cases. And the other issue is that often prostate cancer is multifocal, meaning there's often more than one tumor involving more than one part of the prostate. And so because of that, standard practice for doing surgery is to take out the whole prostate from a cancer perspective. And maybe at some point in the future, when we have better imaging and better surgical capabilities, maybe there'd be a way for us to achieve partial prostatectomy or something like that. But I think more realistically, that would be using various types of energy. And that's a whole other topic, but that's what we call focal therapy. And I'm not sure if there's a talk on that in the lecture series, but that's a whole other hot button issue.
Yeah, and we have one on. See, okay, so very good. I mean, I love that you used an orange as a metaphor, as a descriptor. It's walnuts, things like that, plums, they don't really, I mean, we all understand an orange. We all understand the rind and the flesh, and the juice, So good. See, and actually there's, yeah, I mean, good. We're going to use orange now. So I've got prostate cancer in my orange. Why do you think it's a good solution so that I'm not going to die from prostate cancer?
That's a great question. I think for every patient, it's a really personalized decision, as far as what's best to do for your cancer. And a lot of it has to do with the severity of the cancer as well. But if we sort of ignore those issues and just talk about the potential benefits from a cancer standpoint for prostatectomy, I think the big one is just more information. So prostatectomy is really the only option where we're going to get more tissue for our pathology colleagues to look at, to learn as much as we possibly can about your cancer. With all the other options, whether it's radiation or these focal therapy energy sources that you'll hear about from other speakers, really what we know from your biopsy and your scans is really all we know about your cancer. And so I think that's a major benefit of prostatectomy, is that we look at the whole prostate. So we know if the cancer is growing out of the prostate into the surrounding tissue, if it's growing into those bunny ears, the seminal vesicles, if it's involving lymph nodes, if it's growing into the bladder, et cetera. And so, because it's a lot of information that we can't get any other way currently. And I think that's a really big potential benefit of prostatectomy. And then the other potential area would be for patients who have really aggressive cancer, if they're fit for surgery, surgery in the context of what we call a multidisciplinary approach, meaning we're going to try to hit the cancer from multiple different fronts. Surgery can be really beneficial from that standpoint, in that if we do surgery, you essentially have all the options in front of you for other therapies, which compared to some other options. Sometimes if we do a different type of treatment, surgery may not be on the table in the future. I generally tell patients that that shouldn't weigh in their decision as much as some of the other factors. But for some patients, that's really important to be as aggressive as they possibly can. So in that context, surgery can be really beneficial to be as aggressive as possible. And then the third scenario would be patients who do have the enlarged prostate, where from the benign tissue growing into the urethra, they're having a really hard time peeing at baseline. And in that setting, radiation can make your urinary symptoms a lot worse. And if you're somebody who already gets up 3 or 4 times a night after radiation, you might wake up 5 or 6 times a night, and that's a hard way to live the rest of your life. And so if we take out the whole prostate, we often will alleviate all those urinary symptoms. And from that standpoint, it may actually improve your quality of life. There's obviously trade-offs there, but for some patients, that can be a big improvement in their quality of life.
Years ago, I mean, when I started in the field 20 years ago, I'm a social worker. I mean, I got to stand in and just to watch, some surgeries and stuff, basically just so I knew what I was talking about a little bit. And it only confused me more. But I remember waiting for lymph node dissection and pathology reports with the idea that why put a patient through all the morbidity, side effects and such, if prostate cancer has already entered the lymphatic system through a lymph node site here or there. Is that still done? And actually, can you explain it a little better than I just did?
Yeah, exactly. So the idea of a lymph node dissection is really twofold. The first is staging. So the more advanced a patient stage is, then unfortunately, the worse the prognosis is. And currently, lymph node status is part of the staging. So we currently use what's called the TNM staging system. T stands for tumor. So that's where is the tumor in the organ and how much of the organ is involved. Is it growing into organs around it? And then the N is lymph nodes, and then M is metastases. And so for prostate cancer, that N is important for staging. It impacts prognosis and impacts potential therapy choices for us. So do you, in the context of surgery, do you need additional treatment after surgery? Do we just watch you? What's the best treatment up front? Things of those natures. And then the second aspect is, does removing lymph nodes improve survival and outcomes? And I'd say that aspect is controversial. There's some series that suggest that lymph node dissection could improve survival, but there's other series that contradict it. So I'd say at this point, the jury's still out as far as if it impacts overall survival. But the big reason we do it is just to get a better understanding of your cancer and how best to treat you long term.
So would you ever stop a surgery if you had a positive lymph node?
Yeah, that's a great question. Historically, that was the standard practice with open prostatectomies. So generally in those cases, you would start with the lymph node dissection. If you found an abnormal lymph node and it came back on a frozen section, meaning the pathologist looked at it in real time while you're operating, then often you would cancel or abort the surgery, meaning you would stop and just close. In modern times, it's rare that we do that based on one, just the approach we do for the surgery. The way we approach things with the robot is a little bit different. And so we tend to do the lymph node dissection after we're done with the prostate portion. And the other part is this question about therapeutic benefit. And the idea is, if we leave the prostate in, oftentimes with increasing evidence, you're going to need additional treatment for the prostate itself. And we're already in there, and it makes sense in that setting to take it out to potentially improve survival, but also to minimize potential urinary symptoms down the road from basically prostate cancer growing over time and blocking the flow of urine and things of that nature.
Yeah. So with the robot now, where you have this much better viewport, you basically got, and it's 3-dimensional view, correct?
Yeah, exactly. That's really cool. It's a high def display, about 10x magnification. And then it has a left and a right camera lens, so we see 3D.
Yeah. And you're like looking through goggles or a headset kind of deal.
Exactly. Yeah.
Yeah. Can you actually see the cancer in any portion of the procedure?
Yeah, that's a great question. I wish I could say that the answer is yes, but generally speaking, we see a little bit better than we can see with our naked eye. But for the most part, we just can see shape and color and things like that, and those aren't perfect markers for involvement, whether that's lymph nodes or cancer growing out of the prostate, et cetera. But occasionally we do see feedback. So, if a structure right next to the prostate normally peels off very easily and it's kind of stuck, sometimes that's something that could visually be feedback that there's something going on there. In the case of lymph nodes, same thing. Sometimes they're a little bit stuck to something, or they're very enlarged, and that's something that's easier to see with the robot compared to open. But for the most part, we can't see cancer yet in real time. People are working on that, but that's beyond the current capabilities of our technology.
Okay, so you're now, let's open up the patient, and so you're sitting at a console. I mean, for pretty much all the robotic surgeries, you're sitting at a console, what, 2 meters, 10 feet away or whatever,
Yeah,
patient, and there's another doctor actually on the patient, resident, I guess.
Yeah, it depends on the practice environment. So if you're in a community practice, it might be like a PA or a surgical first assist, or one of your surgeon's partners. If you're seeing somebody in an academic hospital, it's like a university hospital, then often could be a PA or a first assist, but often it would be a resident or fellow. So essentially a surgeon in training, learning how to operate and learning the anatomy, et cetera, of a case, helping your surgeon do the case.
Yeah. But in no case is the patient just laying on a table alone with a bunch of machines in their abdomen.
Exactly. Yeah, that's a really common question we get from our patients. Doc, you just hook up the robot and press a button and come back 2 hours later and you're done. And that's definitely not the case. At least every hospital I know of, the consoles that you're talking about is essentially where the surgeon sits to look into the display and move the little controllers that control the arms of the robot, are in the room with you, generally about 10 feet away. So that way, if something does happen unexpected, the surgeon is able to be right there and take care of the problem.
Right. So when you start surgery, what actually is your goal? And what do you, well, actually, let's back up just a tiny bit. When you're inside and you see the prostate and the surrounding anatomy, I mean, is it a completely new view for you, patient to patient, or are you seeing the same things over and over again?
Yeah, that's a great question. I'd say it's variations of a theme. So we all have the same basic anatomy, but obviously there's slight variation from person to person. For example, does someone have a really big prostate or a really small prostate? And if so, does that impact how thick their bladder is and things like that? Those are all factors that go into doing the surgery and kind of nuances to the way we approach it. And so I'd say there's a little bit of both, where we all have the same basic blueprint, but there's different phases of the prints, or whatever you want to call it, where there's a little bit of variation, and that's where your surgeon's expertise and experience comes into play.
Okay, so now you're inside, and in my mind, it's sort of like you're exploring the Amazon in the 1930s. You've got your pith helmet on or whatever. Aside from the cultural toxicities of people going into the Amazon in the 1930s, but you're an explorer to some degree, as well as a surgeon, and part of the exploration is to figure out what to do. So what are you trying to figure out what to do?
Yeah, I'd say really just getting back on what I touched on, each surgeon kind of has his or her script that, for the way they like to do the procedure. And we all follow the kind of same general principles, but there's definitely more than one way to do most things. And so most surgeons have the way they like to do things, but have to be able to adapt to little subtleties that might change the script of the operation. And so the things that we're looking for when we do a case is just what I was talking about. Is the bladder thickened from having a big prostate and the bladder having to work really hard every time you pee? Is there a really small prostate that might make it a little bit more challenging to define the boundary between the bladder and the prostate? Things like that. When it comes to nerve sparing, kind of getting a good feel for where those nerve bundles travel alongside the prostate. In the case of cancer, is there some sort of abnormal bulge on one side of the prostate, or is it a little bit stickier, like I was talking about? And if so, maybe you're planning on doing a nerve sparing on the right, but there's a bulge there that you couldn't feel on exam. Or if you had some, preoperative MRI or something like that, just it was unclear if there was cancer there, but now we're seeing something and having to deviate from that script.
And
so
what do the nerves, oh, sorry.
No, go ahead.
What do the nerves look like?
Yeah, they're very fine. I'm trying to think of the word. They're thicker than a hair, but they're very thin, almost like little ribbons, I would say, traveling along the blood supply of the prostate, kind of attached with a layer around the prostate. And so with the naked eye, they're pretty tough to see. When we used to do open surgery, surgeons often wear what are called loupes, which give you some magnification, often about 2.5x. So it's sort of like reading or wearing reading glasses, and you can kind of make the fibers out a little bit. With the robot, they're definitely more pronounced, but they're still very thin, delicate structures. And so we're just trying to see those bands and preserve as many of those little nerve bands as possible. In most, generally speaking, it's not like a discrete solid nerve. They're multiple little fibers kind of worming their way down from the spine along the prostate to get to the penis.
And these fibers, are they like in a tube kind of setting, or are they spread out like in a fabric kind of deal?
Yeah, it's more spread out. That's a really good way of describing it. And they are kind of in almost like a fabric, like you're saying. So there's tissue around the prostate and most of our organs, what's called fascia. And so there's a layer of this fascia tissue that kind of covers the prostate. And those nerve fibers are essentially kind of squashed between that fascia layer and the prostate. And so when we're doing that nerve sparing, we're trying to peel that tissue off the prostate. And there's kind of varying degrees of how much we take based on how aggressive the cancer is, how much of it, and where. And so there's anywhere from no nerve sparing, partial nerve sparing, and then for sort of full nerve sparing, there's a couple different very nuanced techniques as well. Just do we trying to get every possible fiber, or maybe a slightly less aggressive approach would be like something in the order of like 98% or something like that to try to quantify it. But so there is some variability there as well.
Yeah. And do the nerves get damaged? The ones that are preserved, but are they still useful, or they got to recover from something?
Yeah. So, I think even in perfect hands, there's going to be some trauma to those nerves, because we do have to essentially peel them off the prostate. And so there is a little bit of tugging and there's a little bit of pulling. And part of that tugging and pulling is just being able to position things so that we can see it. So when we do surgery, we have to kind of pull the prostate over a little bit so that we can kind of see around the corner of it to see those nerve fibers. And so there's always just a little bit of tugging and pulling on things. And so because of that, even if you have the perfect surgery, when you wake up, things are probably not going to work exactly like they did when you went to sleep. And another factor there too is even if there's no tugging and pulling, everything's going to be inflamed, and that inflammation is going to impact the nerve fibers as well. And so even in perfect hands and the perfect outcome, there's normally a period of at least several weeks or several months where things don't work like they did, and men will notice gradual improvement. And as a surgeon, my hope is that it's more in the order of several weeks to several months, but unfortunately sometimes it's beyond that. And sexual function can improve to up to 3 years after surgery.
Right, and it's worth the damage, the length of time. It's not so much that you cut something; it's that there's inflammation and trauma and subtle things, involved in all that. It's just healing and recovering time for that part of your body.
Yeah, exactly. And in some cases, from the tugging and pulling, it's sort of, an analogy would be somebody who has like a really bad ankle injury or knee injury, something where you might stretch a nerve in your lower leg that could lead to weakness in your ankle or something like a foot drop. And over time, those symptoms will get better, but the existing nerve fibers kind of serve as the skeleton for the new nerve fibers to kind of grow down and get back to their target. And so in this case, be trying to get from the start of the prostate to the base of the penis. And for an average size prostate, that might be 4 centimeters, which is about 1.5 inches. And nerves don't grow very fast, like something like 1 to 2 millimeters a month or so. And so if you do the math, it kind of makes sense why in some cases it might take 3 years to get full recovery of your sexual function, or whatever that full recovery is going to be. I wish I could say that every man's going to end up the way he was when he went to sleep. But in some cases, a full recovery might be only getting 25% of your erections that you used to have back, or it might be 75 or 80. Everyone's different, and there's a lot of factors that go into that. But that is why it takes so long. It's just that nerves heal and regrow very slowly.
And there's no way to predict this.
Unfortunately, I wish our prediction tools were better. There are some factors that have been identified that help us predict, but nothing's perfect. And so the 3 things that really help us out are age. So younger patients tend to do better than older patients. And I think that one intuitively makes a lot of sense. If you're younger, you're probably going to heal a bit faster. And so that helps you out. And the second is your sexual function going into the operating room. We can't make you any better than you are before surgery. And so if you have so-called like 10 out of 10 erections, similar to what you did when you were a 20-year-old kid, then for you, if you get back 80 or 90% of what you had before surgery, then there's a good chance that that's going to be enough to maintain your sex life. But if unfortunately you only are functioning at maybe like a 5 or a 6 out of 10 going into the operating room, if you get back 80%, that may or may not be enough to have intercourse long term. So that's a big factor. And then the third one is how much of the nerves are we able to spare? So are we able to spare both nerves in close to completion or completion? Or are we able to only spare one? Or in the case of a really bad cancer, do we have to take both nerve bundles to try to give you the best chance of getting your cancer out? And so all those factors influence the likelihood of maintaining sexual function adequate for intercourse long term, and account for why there's such wide variability in the literature. So there's ranges anywhere from something like 35 or 40% up to 80 or 85% of men maintaining their sexual function. There's just so many factors that go into it.
What do you think of, I mean, without naming names, but what do you think of doctors who say that all their patients, 90 to 95%, come out with, erectile functioning within a year?
Yeah, I would personally would probably question that. Obviously, some surgeons are better than others, but I don't know that anybody's perfect. I suppose if all you did was operate on 45-year-old men who had perfect erections at the time of surgery, who had lower grade cancer, then maybe that's a possibility. But in general practice, I would personally question that.
Yeah, and it's a shame because I could right this minute think of 2 hyper well-known semi-celebrity urologists.
Yeah, for sure.
And I mean, one of them actually, there's a YouTube thing of him saying at a grand rounds that like, there's no reason for anyone to experience erectile dysfunction after radical prostatectomy. And, that's just nonsense. But I mean,
Totally.
This is a guy who, everyone respects him. And then another one we can get into off camera perhaps, but there are a lot of issues with the limited time. We'll do urinary incontinence in 55 seconds, but in 50 seconds, why do men experience a shortening of their penile length?
Yeah, that's another hot button issue for sure. I think it's really twofold. The first is, our penis is a fixed length, and when we take out the prostate, we have to reattach the bladder. Generally, the bladder is way more flexible than the penis, but there is potentially a little bit of tension that might pull the penis up a little bit. So I think that accounts for some of it. And the other aspect is just differences in blood flow. And so right after surgery, there's differences in the blood flow into the penis from the surgery itself, but then also the changes in the nerves. It's just not going to have the same blood flow. And those 2 factors add up to, at least at first, the penis often being, somewhere around a ½ inch or so shorter than it was before surgery. Most theories would suggest that over time, most men get the majority of that length back, but that's not true for everybody.
Yeah, and we tell our guys, like, you've got a cell phone, get a ruler before surgery, get an erection, take a photo of your penis, erect penis, take a photo of your flaccid penis with a ruler next to it. So that, not that, you should, lay the grounds for a lawsuit or anything, but that you should be able to know with precision what your experience post-surgery is. So many men will fantasize, I just lost 2 or 3 inches. I was a really big guy. When really, if you compare pictures pre and post surgery, you know, it's half an inch or whatever, you know, whatever. Yeah. So let's do urinary incontinence, which is a huge issue for men everywhere around surgery. Why does that happen?
Yeah. And I'll just take a step back just to get what you're talking about. You know, when I see my patients, I talk about really the 3 goals of surgery. I think from a quality of life standpoint, obviously overall length of life, the first priority is cancer control. And the second priority is urinary control. And the third priority is sexual control. Because obviously if you have bad cancer and you're dying, the other 2 don't matter. And you know, from everyday life, you know, being able to be active, exercise, hike, whatever, even going to the grocery store, you know, being dry is a big deal. And if you're leaking urine all over, you're probably not going to have sex anyway. And so generally, you know, the thing that if something has to get sacrificed, it's generally sexual function. Obviously, some men will be very vocal, and that's for them more important, and that maybe that changes things. But for the majority of patients, you know, cancer control, urination, then sexual function. And with that, you know, just why does it happen? I think that the anatomy diagram here is really helpful for that. And what I like in everything too is knee surgery. And so if you have your knee operated on, the muscles above and below the joint get weakened from the trauma and then inactivity from the surgery. And then you have to rehab those muscles back up to be able to walk again or run again, whatever. And it's really the same thing here. So we have our prostate here with, again, the urethra running right through it. And then the 2 structures that keep us dry are first the internal sphincter, which is the bladder neck. And that one's really lower down on the priority list. And the most important one is the external sphincter muscle here, which is really part of the pelvic floor. And in most of these diagrams, they actually show a little space between the prostate and the muscle. And if that was true, we would be a lot better as surgeons as far as our outcomes. But in reality, those sphincter muscle fibers peak up onto the very bottom of the prostate, what we call the apex. And so when we do a prostatectomy, as we talked about, we have to divide the bladder neck. So in other words, the internal sphincter. And then we have to try to very carefully push those muscle fibers of the external sphincter off the apex of the prostate, the bottom of the prostate, to preserve as much of those muscle fibers as possible. And then when we hook things back up, we sew the bladder back down to the urethra, right at the sphincter. And so, like I said, it's a lot like knee surgery where we've taken the prostate out, but because of everything involved, the bladder neck fibers get traumatized and get weakened. The sphincter muscle here gets traumatized and weakened. And then you have a catheter after surgery, often for about a week. And so you're not really using those muscles for some time after surgery as well. And so when all those things add up, those muscles are weak. And so you have to rehab back up with what are called Kegel exercises. In some cases, we'll have you work with a physical therapist who specializes in the pelvic floor. And at least here, and I think a lot of other surgeons will actually have you do those exercises before surgery. The idea being if you're stronger going into the OR, then hopefully the valley after surgery isn't quite so low. And so that's why men leak. And you know, generally speaking, when the catheter first comes out, everyone leaks. And if you didn't leak, oftentimes that can be a red flag, you know, something too tight or something like that where you're having a hard time peeing. But urinary control returns much faster than sexual function. And you know, by and large, over the first 6 to 12 weeks after surgery, most patients notice a very rapid and significant improvement. I wish I could say that at 3 months, every man is dry, but you know, by the 3-month period, you know, somewhere around maybe a half to a third to half or 2/3, depending on your surgeon and kind of the intricacies of your particular situation, will be dry, with the majority of the rest maybe having 1 to 2 damp pads. And then by about 1 year after surgery, about 90% of men are using less than a pad a day, so more or less dry or dry altogether. But about 10% of men will have some leakage long term. For the most part, men are able to adjust and do all the things they like to do. You just have to wear a pad and to compensate for that. And with modern surgical techniques, the risk of having significant leakage, meaning multiple soaking wet pads or like a Depends, is about 2 to 3%. So it's not zero, but it is pretty close actually.
Yeah. And should patients be thinking in terms of there's nerve sparing surgery, but is there also urinary sphincter sparing surgery? In other words, are there times where you just have to cut it out?
Yeah. Yeah, I think that there's definitely a component of that. So there are cases, for instance, if we know the cancer is like right up against the sphincter and we're concerned that it could be protruding out, we might have to sacrifice a millimeter or two of sphincter muscle in an effort to get all the cancer out. And so that sometimes does play a role. And actually, since you mentioned nerve sparing, there's some data that doing nerve sparing also improves urinary control after surgery. And it's unclear if that's because the nerves are involved, probably not. It's just that if we're sparing the nerves, by definition, we're going a little bit closer to the prostate. And so that facilitates sparing some more of the prostate, or sorry, the sphincter tissue to help with the control afterwards.
What else, what other kinds of damage could you do during prostate cancer surgery?
Yeah, I'd say, by and large, the big ones are the things we just talked about. But the kind of the rare things, the big one that we worry about is a rectal injury. So again, the rectum is right behind our prostates. So when we do that surgery, we have to push the rectum off the prostate. And because of that, there's a very small risk of something happening. And someone who's ever had pelvic surgery or never had radiation, that's extremely rare, but it is something that could happen. So you do have to tell your patients about that. But that's the big reason why surgery after radiation is really challenging, because after radiation, the rectum ends up stuck to the prostate and it can be really tricky getting that down safely. And then aside from that, there's kind of the typical risk of surgery. So things like bleeding, infection, which is rare. And then in the course of the lymph node dissection, the nodes that we're removing are along the blood vessels in the pelvis and either side of the bladder and the prostate. So there's a very small risk of injuring one of those blood vessels while we're taking those nerves out, or sorry, the nodes out rather, sorry.
So with open surgery, your surgeons got their gloved hand taking out the prostate. How do you get the prostate and seminal vesicles out with a robot?
Yeah, so we do the surgery. We basically have a device that has a pole, and so we put the pole into the port, and then you slide a insert out that opens a little baggie, and you drop the prostate into it and then cinch it up. So it's all contained in a plastic bag. And at the end of the case, when we're all done, we take out the ports, which are the tubes that go into the body, and we make one incision just a little bit bigger to pull it out.
So, and I'll just ask, is it possible that surgery actually helps cancer cells escape into the rest of the person?
Yeah, that's a question we get quite frequently. And I would say that in current times with modern surgical techniques, there's really no data to support that. But I definitely understand the concern of patients being worried about that. When we're doing cancer-related surgery, our number one priority is not spilling cancer. And so we take very careful measures to avoid cutting into cancer, putting the organ in a baggie, for instance, so it doesn't touch anything, things of those natures, to try to avoid that.
Yeah, and do you do anything to sort of like coat or pour like saline solution in after the surgery to kill off whatever there may be the 1 in a million chance?
Yeah, exactly. Yeah. So at the end of surgery, whether that's open surgery or laparoscopic or robotic surgery, standard practice is to irrigate out the field where we're working. And so in the case of a prostatectomy, the pelvis. And it's really threefold why we do it. One is if there is any cancer cells, we're trying to wash those cells out. The second is to reduce the risk of infection. And so if there's any bacteria that were introduced, we're trying to flush those bacteria out. And the third is that it helps us wash away any clotted blood that's kind of accumulated during the course of the surgery, so we can look for bleeding as we're finishing up the operation to stop that before we end.
And just more around visualizing, once the prostate is out, but the nerve bundle, if you've spared, let's say, both sides, both nerve bundles, are they just now dangling in midair, or how's that? What does that look like?
Yeah, the nerve bundles.
Yeah.
Yeah. So when we successfully spare the nerves, because like you said, they run more or less kind of like bands going from the bladder up to the urethra. Before we reattach the bladder to the prostate, there is normally just like that. There's sort of two bands of tissue running from the bladder towards the urethra. And so if we're not able to spare those nerves, then those bands aren't there. And so it's just sort of bladder with a gap to the urethra in front of the rectum.
Right, but if they are there, I mean, this is what we're back to the orange. The nerve bundles are resting on the orange. The structure of the orange is actually supporting the nerve bundles. But you've taken the orange away. Now we're just stuck with these fibers, these ribbons. Are they just exposed inside and they're left to fend for themselves without any structure to rest on?
Sure, yeah, good question. So because they run right in front of the rectum, they're still more or less kind of supported on the backside by kind of the edges of the rectal and tissue adjacent to the rectum, as well as some of the pelvic floor musculature.
So they're not neglected. They're still
exactly, yeah. They're not just kind of flapping in the breeze, so to speak.
And there's no breeze left. I mean, there's still. I mean,
exactly.
Yeah. So this sounds like, and we'll talk another 5 or 10 minutes. But this sounds like an extraordinarily. I mean, it is. It's not. It's not pulling a molar out of your mouth. Not to belittle dental surgeons, but it's stuff that you got to spend a lot of time learning how to do.
Sure.
How is it that patients could go home from the hospital after just one day?
Yeah, I think that's one of the biggest advantages of the robot. Is a lot of the things that keep patients in the hospital are things like pain or bowel issues. When it comes to the prostate, or fortunately for us and our patients, those systems aren't really impacted a whole lot. So a prostatectomy is a very complicated surgery in that we're not only removing something, but then we have to reconstruct things as well. And that's why it's such a challenging operation, and why experience is important, and why unfortunately the things that we were just talking about, sexual dysfunction and changes in urination, occur. But fortunately for us, as far as things that can keep people in the hospital, generally very little is impacted. So we generally don't manipulate the bowel very much, if at all. It's normally a relatively short anesthesia time. And then because it's just small little incisions in the belly, often pain isn't very bad after surgery. And so many men are able to get by without needing anything more than Tylenol or Motrin and medications in those classes. And so because of that, that facilitates getting people home as quickly as possible afterwards.
And that sounds super. That's what can patients, what do you think could be improved about the surgery? I mean, we have the robot, and they're, like any kind of like laptop computers and such, there are improvements annually for that. What might be the next dramatic change in prostate cancer surgery?
Yeah, I'd say probably two things. The first is over the last year to 2 years, there's some advancements in the techniques that have been described. There's something called Retzius sparing surgery. There's the space of Retzius is the anatomic potential space, if you will, in front of the bladder that anchors the bladder to the abdominal wall. And so there's this technique now that's being described where you, instead of dropping the bladder down from the abdominal wall to get to the prostate, you leave it up to provide support to the bladder and potentially the sphincter muscle and things of that nature. And at least in early clinical trials, looks like those techniques may improve urinary control and possibly sexual function. So I think that might be something that, right now, I would say we're in the sort of early adopter period where it's gone through initial clinical trials, and there's an increasing number of surgeons learning the technique, but it's definitely not the majority of surgeons. But maybe in 10 years, these techniques will be the new standard of care. And so that may lead to a big advancement as far as urinary control and things like that. And then I think the second one will be our ability to try to image cancer cells in real time in the OR. So there's several groups working on various types of technology to try to do, where you pass in like a probe to put it on the prostate to see, is there cancer right there at the edge? And if so, where is it? Can I take this whole nerve, or do I need to, leave a little bit, et cetera? And so I think that'll be a big advancement probably in the next 10 years or so, where we're able to actually see the cancer at the microscopic level to help us improve our positive margin rate, meaning cancer right at the edge, helping us decide on how much of the nerves to spare. Can we save a little bit more sphincter muscle, things like that. And hopefully all those things would add up to both better cancer outcomes, but also quality of life outcomes as well.
And as we close this, and really good that I think our audience now has a pretty good visual understanding of what's going on, you know, and not just from looking at graphics with flaccid penises, but the idea of just really grokking or understanding what you and your colleagues are doing in there. What do you wish your patients would be telling you or asking you that most sort of fail to do?
Yeah, that's a great question. You know, probably the big one is, you know, just in the big picture, you know, what do I look like in 6 months or 3 years, you know, that kind of thing, and what's my quality of life like? You know, I think that's the big thing. And I think another big one would be just a lot of us have patient advocates who are, you know, men who have gone through the surgery before and have made themselves available to talk to our patients, you know, considering surgery. So I think that's a big thing, you know, asking your surgeon if they have patient advocates that they can talk to just to talk about their experience. Because, you know, I think the unknown is always the scariest part of any decision making, but especially when it comes to cancer diagnosis. And so when you're confronted with options to treat your cancer, then and all of them are going to impact very intimate parts of your life, whether that's urination or sexual function, just getting a better understanding what it actually means to live with a little bit of leakage or to live with an erection that might be 70% of what it used to be. I think that can be really helpful in just understanding what it actually is to be a prostate cancer survivor a year or 2 years out from surgery.
Great. And to live is obviously the whole reason we're doing any of this stuff. Yeah. And, you know, part of the deal for support groups and patient advocates and such is that if this was as simple as with as few consequences as extracting a molar, in other words, if you didn't risk urinary side effects, erectile dysfunction, and, you know, other miseries, we probably wouldn't need to be doing this. You know, I mean, if you got diagnosed with prostate cancer, I mean, of course, you know, ask questions and choose doctors wisely, et cetera. But the quality of life impact would be just go and do it and hope for the best, you know.
Sure.
You know,
It'd be a really easy decision, right? If it was an organ that, you know, like we talked about before, if you weren't worried about having babies in the future and weren't worried about your fertility, if there were no other consequences, you know, if you're 65 or 70, for the majority of our patients anyway, oh yeah, just get it out, no big deal. You know, I'll leave the hospital the next day, I'll be back to my normal self in 3 to 4 weeks, cool. But obviously we're not so lucky, and there are real ramifications for some men.
Dr. Schade, thank you for this really cool conversation and for sharing literally your insights into prostate cancer surgery. I think we all now have more insight and understanding of what's involved. And, you know, for those considering surgery, I think they'll be wiser and more satisfied whether they choose it or not, you know, based on having heard all this. So thanks for that, and welcome to our conference.
Yeah, well, thanks so much for having me. It's been a real pleasure to be a part of it.